Myself, Ashifa Sanofer, studying BSc Radiography and Imaging Technology, third year at Government Keel Park Medical College and Hospital, Chennai. So today, I'm going to present on the topic Placenta accreta spectrum, a growing catastrophe in the caesarean era. Let's begin with the introduction. A placenta accreta spectrum, PAS, is a disorder of abnormal placental implantation characterized by the pathological adherence of chronic villi to the myometrium due to the defective visualization. Its incidence has risen sharply with increasing caesarean rates. That's the main cause, rates making it PAS a major cause of life-threatening obstetric hemorrhage, maternal morbidity in the modern caesarean era. Aim of my study, I compare ultrasound and MRI in the evaluation of PAS with the emphasis on assessing the depth and extent of PAS and determining the superiority in preoperative diagnosis. Let's see the key overview. PAS, it is classified into the epidemiology and etiology. Epidemiology shows increasing incidence, high-risk pregnancy, maternal morbidity, obstetric hemorrhage, peripartum hysterectomy. Etiology includes caesarean section, placenta previa, uterine scarring may happen, multiparity, advanced maternal age is also a cause. Let's see the pathophysiology of PAS. Those images shows the normal placenta, abnormal implantation, placenta accreta spectrum. Let's see about normal placenta image. There is a normal decidual presence. We can see the placenta can be separated easily. There will be minimal bleeding that is commonly happen. Abnormal implantation, there will be defective residua due to the uterine scar defective. And there will be abnormal attachment of the placenta to the uterus, increased adhesion may happen. We can see the PAS as my topic, chronic villi invade into the uterus, placenta cannot detach, so it will may happen more hemorrhage. There will be a severe hemorrhage risk. We can see the classification of PAS. It is classified into placenta accreta, increta and percreta. In globally, increta is 17%, percreta is 5%, accreta is more, which is 78%. We can call it as easily in accreta attachment, increta invasion, percreta penetration. Why imaging is important in PAS? In early diagnosis we can ask, it assists the invasion depth, proper surgical planning, it reduces the hemorrhage risk, improve maternal outcome we can get. Role of ultrasound in PAS. It is a first-line imaging modality for PAS. It is widely available, non-invasive. We can use it for the highly risk pregnancy patient. We can have the color Doppler ultrasound improves detection by showing the abnormal vascular patterns because the uterus is highly vascular. We can see the image, normal placenta and adherent placenta. In normal placenta, there is a clear retroplacent clearance, we can see it out. In adherent placenta, it is absent. Why we use MRI? Superior soft tissue contrast, it clearly differentiates the placenta, myometrium and surrounding pelvic organs using the MRI. Accurate assessment of the invasion depth of placenta, it helps to distinguish the increta, accreta and percreta. Better evaluation of the posterior placenta we cannot see in the USG. It is not limited by the placental portion like ultrasound. Larger field of view because in ultrasound we can move it out and we can see the certain planes only. But in MRI we can see the whole plane by providing a complete visualization of the uterus, placenta and adjacent organs like urinary bladder. Detection of the extrauterine involvement, it identifies the invasion into the bladder and surrounding pelvic structure as I said already. Patient positioning, we have to place the patient in a supine position with left lateral tilt to avoid the compression of IVC, ensure the patient should be in a comfortable position and give the cushions to reduce the movement. As a radiotech, we have to do some patient preparation. We have to explain the procedure completely to the patient and obtain written consent from the patient for the permission of the procedure. Screen for MRI contraindication like metal implants and pacemakers. Moderately fill the urinary bladder for better visualization. Ask the patient for fast for 4 to 6 hours, but it is not mandatory, we can do it whenever needed. Comfortable patient positioning is very mandatory. Coil selection, use a phase array body coil or pelvic coil for high resolution images if needed. Place the coil directly over the patient abdomen or pelvic region. What are the MRI sequence for PAS? T2 imaging and T1 imaging is mainly classified as. In T2 imaging there is a HAST and FISTA. In HAST we can use it as sagittal, axial, coronal. In sagittal plane we can see the uterine bladder interface and placental depth, we can see the clearly. In axial plane lateral extent uterine contour we can easily see, and coronal plane placental thread and myometrial thinning is seen. In FISTA, high resolution placental morphology and vascularity can be clearly seen. In T1 imaging axial, detect the intraplacental hemorrhage. Optional sequence are diffusion and contrast enhanced. Key MRI features of PAS. We can see dark intraplacental bands, myometrial thinning or loss, placental bulge or irregular contour, abnormal placental bladder interface, the last one abnormal vascularity or flow voids. These are all the features we can easily see in the T2 sequences. What are the MRI evaluation in PAS? Multiplanar imaging, it gives a superior spontaneous soft tissue contrast, better evaluation of the posterior placenta, detect the extra-uterine invasion, and improve the surgical planning, and it improves the maternal outcomes. It is the comparison between the ultrasound. We can call it is the ultrasound as a first-line screening tool, but MRI is a problem-solving complementary tool. Availability, ultrasound is widely available. We can do a bedside also, but MRI, which is a limited availability, it is the main advantage. Cost, ultrasound is low cost. Magnetic resonance expensive. We need for the same waves only, so it doesn't matter about the expensive. Imaging in ultrasound has a limited use, but MRI is a multiplanar imaging. Operator dependence, ultrasound is highly operator dependent, so we need more experience to find out whether it is percreta, increta, or accreta. MRI is less operator dependent. This is the case presentation 1. This case represents the marginal placenta previa with placenta increta. The images are normal placenta, previa, and increta. I arrow mark whether it is a previa or increta. The findings are multiple T2 intraplacental hypointense band seen at its car site with a retroplacental T2 hypointense zone and myometrial thinning is zone. Case presentation 2. This case represents the low-lying placenta, type 2 placenta previa. The images are normal placenta previa in a coronal plane. The findings are left lateral placenta seen, the lower edge of placenta seen up to the margin of internal os. Case presentation 3. This case represents the complete placenta previa with placenta accreta. The images are normal placenta and accreta. The findings are on T2 sequence, retroplacental clear space not visualized with myometrial thinning noted. Case presentation 4. This case represents the grade 3 placenta previa with placenta percreta. The images are normal placenta, previa, and percreta. The findings are focal loss of T2 hypointense placenta, myometrial interface in the anterior aspect of lower uterine segment with the T2 hypointense placental bands extending from the placenta and to myometrial interface. This is the last case, case presentation 5. This case represents the complete placenta previa with placenta accreta. The image I have shown is normal placenta and previa and accreta. The findings are retroplacental disruption of the hypointense line at myometrial interface in the lower uterine segment without serosal invasion is seen. Discussion. In my study, MRI was a valuable imaging modality in evaluating the parts, providing a detailed assessment of placental anatomy and its relationship with the uterine wall. It helps to identify the abnormal placental attachment and assess the depth of myometrial invasion while also enabling evaluation of the overall extent of placental involvement. In case the ultrasound were inconclusive, MRI offered additional anatomical detail and improved diagnostic confidence. Its multiplanar capability allowed assessment of surrounding structures and detection of possible extra involvement we cannot see in the ultrasound. Overall, MRI complemented ultrasound and supported better clinical decision making and surgical planning to improve the maternal outcome. Conclusion. So I conclude that MRI offers a superior anatomical delineation in pairs, accurately assessing the depth of placental invasion, while ultrasound is the primary modality. Its accuracy is limited by the operator and maternal factors. MRI enhances the diagnostic precision and supports the effective preoperative planning. These are my references. I sincerely express my gratitude to Dr. Gopinathan K. Sir, Head of the Department, and Mr. Marimuthu C. Sir, Senior Radiographer, along with all the faculty members.